Dear learners, in the previous module we learnt about the communicable diseases, spatial epidemiology and the trends or patterns of diseases in various regions of the world. I am Professor Swati Rajput from Department of Geography, Shaheed Bhagat Singh College, University of Delhi, and author of the book Geography of Health by Concept Publications. Welcome to part 2 of the module on communicable diseases. The objectives of this module are to trace the history of communicable diseases in India. We will identify the pattern and trends of communicable diseases in India. The third objective is to understand management of communicable diseases in India, to differentiate between communicable and non-communicable diseases, and briefly understand the epidemiological shift in India. The history of infectious diseases in India can be traced back from the cholera pandemic. Studies show that during the 19th century, the cholera epidemic severely affected British colonized India on several occasions in 1817, 1829, 1852, then in 1863, 1881 and 1899. The majority of these impacted by the pandemic were rural people and slum dwellers, mostly in Punjab, Delhi and United Province, now called Uttar Pradesh and Uttarakhand, in northern India. It gradually moved to the other provinces, with the Madras Presidency being severely affected in 1877. Major provinces of Calcutta, Madras and Bombay recorded instances in 1899. The pandemic expanded to neighboring nations each time it struck individually, including Russia, China, Arabia, Persia and United States. A large-scale cholera affected outbreak was also witnessed in 1992 in the southern peninsular India. Cholera outbreak in Odisha affected 34,111 people, including 33 deaths. Plague, before we trace the history, let's understand the difference between two types of plague that India has witnessed, that is pneumonic plague and bubonic plague. When the infections are localized in the lymph gland or ducts, it is referred to as bubonic plague. If organisms causing plague are localized and cause infection within the lungs, it is referred to as pneumonic plague. In 1895-96, plague pandemic gripped the cities of Bombay and Calcutta that had seaports which were believed to be the port of entry of the infection. It later spread to other parts of the country and continued till 1918. In the span of 10 years between 1898 to 1908, around 5 lakh people got infected. In India, bubonic and pneumonic plagues were first reported in Bombay, now called Mumbai, in 1896. Bombay was one of the most important ports and commercial centers in India during colonial times. The city was inhabited by 8 lakh people. The municipal committee at that time instigated a policy of isolating plague victims, disinfecting or destroying infected dwellings, and inspecting travelers. However, these measures are not only failed to stem the spread of the disease, but also proved unpopular and intensified the mass migration from the city which had been caused by the outbreak. By March 1897, hundreds of thousands of people had fled and the plague's death toll stood at around 20,000. It had also begun to spread inland and would eventually afflict many parts of the country, leading to thousands of deaths and widespread fear and panic. In September 1994, the city of Surat in the state of Gujarat in western India witnessed a plague. It was a pneumonic preceding a bubonic plague. Around 2 lakh people fled from city. It got spread to the 5 states, namely Maharashtra, Gujarat, Karnataka, Uttar Pradesh, Madhya Pradesh and New Delhi. According to the studies, the ultimate cause as 1993 Latur earthquake, which caused a large number of homes to be abandoned and food grains inside. This destabilized the population of domestic and wild rats, in which the plague is endemic. allowing transmission of the plague from wild rats to domestic rats to the people. The flood in Surat led to spread of dead rats in open streets, and later the people came in contact with these rats, leading to spread of disease. Almost 80% of the infectants belonged to slum areas. Now let's talk about influenza or flu. The 20th century witnessed the most devastating pandemic that resulted in the death of 20 to 50 million people worldwide due to the Spanish flu. The evolution of pandemic influenza evidence from India 1918 or the Spanish flu influenza caused by one of the H1N1 strains of influenza virus. It emerged in 1918, and during autumn of the same year, a second severe wave of the flu re-emerged and affected the whole world. The second wave began in Bombay in India and spread to northern India, Sri Lanka, and then across the world. In terms of fatalities, the India was a focal point of the epidemic with an estimated death of 10 to 20 million people. One of the reasons for the epidemic to have subsided later in India is the weather. Humidity acts as a barrier to the survival of influenza virus and its transmission. India has experienced several influenza outbreaks since then, including the H1N1 swine flu pandemic in 2009. Influenza typically spread through respiratory droplets when an infected person coughs, sneezes, or respiratory diseases. According to the latest Global Burden of Disease Report 2017, India has one of the highest burden of chronic respiratory diseases. India contributes to 15.69% of global chronic respiratory diseases, but 30.28% of all deaths due to chronic respiratory diseases occur in India. India has the highest number of COPD, that is chronic obstructive pulmonary disease, cases in the world, a whopping 55.23 million. The second largest number of global deaths due to COPD, almost 0.85 million, occurs in India. The data shows that Uttar Pradesh has the highest number of asthma cases, followed by Bihar, Odisha, Rajasthan, West Bengal respectively. Tuberculosis is one of the many different respiratory diseases that created havoc in India for years. India has the highest TB burden in the world with an estimated 3 million cases and 2,80,000 deaths annually. This is about 1/5 of all TB cases globally, and India accounts for 38% of TB deaths worldwide. In India, according to National Tuberculosis Institute, TB is responsible for 53 deaths per lakh population per year. The mortality is higher in older age people. India accounts for 27% of global estimated 10 million cases and 25% of estimated 1.6 million deaths. In 2021, the state of Uttar Pradesh notified highest number of TB cases, followed by Maharashtra, Rajasthan, Madhya Pradesh, Gujarat, West Bengal respectively. Very less cases were being reported in northeastern states and states of Jammu and Kashmir, Himachal Pradesh and Uttarakhand. Reported TB deaths total decreased across 28 states, with the largest percent decrease being seen in Lakshadweep, Andaman and Nicobar Islands, Andhra Pradesh and Manipur. Notably, there was a decrease of 3,496 total TB deaths in Uttar Pradesh over this time period. Total TB deaths increased in 7 states, with the largest percent increase occurring in Goa, Arunachal Pradesh and Jharkhand. Next category is vector-borne diseases. Vector-borne diseases in India includes malaria, chikungunya, dengue, filaria. That creates havoc in different regions of the country every year. Let's talk about the most prominent one, that is malaria. In India, 9 anopheline vectors are involved in transmitting malaria in diverse geoecological paradigms. About 2 million confirmed malaria cases and 1,000 deaths are reported annually, although 15 million cases and 20,000 deaths are estimated by WHO Southeast Asia Regional Office. About 88% of malaria cases and 97% of death cases due to malaria in India were reported from the highest disease burden states, namely northeastern states, Odisha, Andhra Pradesh, Maharashtra, Gujarat, Rajasthan, West Bengal and Karnataka. At the state level, Odisha contributes to 25% of the malaria cases, followed by Chhattisgarh, West Bengal, Jharkhand and Karnataka respectively. Together, these states contribute to around 90% of the malaria cases in India. Odisha, with its humid and hot climatic condition, is highly conducive to malaria transmission, 91.5% of which is caused by P. falciparum and 8.5% by non-falciparum species. Food and water contaminated diseases are other set of infectious diseases that are very common in India. Due to poverty, unhygienic conditions and lack of safe drinking water, these diseases cause various digestive and abdominal issues, causing deaths in many cases. Typhoid fever is a bacterial infection caused by bacterium Salmonella typhi. The disease is commonly transmitted through contaminated food and water and is particularly prevalent in regions with poor sanitation and hygiene practices. In India, typhoid fever has been a significant public health concern for many years. The disease has caused significant morbidity and mortality, particularly in rural areas where access to health services is limited. The first cases of typhoid fever were recorded in India during the British colonial period, and since then the disease has continued to be a concern. In recent years, there has been a decline in the incidence of typhoid fever in India following successful public health interventions such as vaccination and improvement in sanitation and hygiene practices. However, the disease still remains a significant public health problem, particularly in certain states. Typhoid cases are highest in Uttar Pradesh, followed by Bihar, Madhya Pradesh, Gujarat, Rajasthan, Maharashtra, Assam and Odisha respectively. Other food and waterborne diseases in India includes typhoid, cholera, hepatitis A, jaundice, etc. Sexually transmitted diseases. In India, the sexually transmitted infections, that is STI, are mainly diseases like syphilis, gonorrhea, chlamydia and trichomoniasis. The other four are incurable, that is hepatitis B, herpes simplex virus, HIV and human papilloma virus. They are caused by sexual transmission. Now coming to HIV AIDS, according to 2021 statistics, India has 2.4 million people with HIV and 42,000 AIDS related deaths happened in 2021. As per the recently released India HIV estimation report, that is 2019, overall in the estimated adult HIV prevalence trend has been declining in India since the epidemic's peak in the year 2000, and later it has been stabilized in recent years. The estimate for this indicator was 0.22% in 2019. In the same year, HIV prevalence among adult males was estimated at 0.24% and among adult females it was 0.20%. Now, at the subnational level, there are 3 states with the highest adult HIV prevalence, that is northeastern part of the country, namely Mizoram, Nagaland and Manipur. Other states or union territories estimated to have adult HIV prevalence higher than the national average were Andhra Pradesh, Meghalaya, Telangana, Karnataka, Delhi, Maharashtra respectively. Since 2007, the number of AIDS related deaths started to show a declining trend. Annual number of HIV AIDS related deaths has declined by 54%. In 2015, an estimated of 67.6 thousand people died of AIDS related causes, and the reason for the decline is government targeted intervention and the programs to make people aware, HIV testing to identify, and then the vaccinations which were being initiated. If we see mortality due to infectious diseases in India, we see that in India, pneumonia is responsible for around 23% of the total deaths, followed by acute respiratory infection, H1N1, acute diarrheal disease, which is around 10%. Learners among the causes, air pollution and water contamination are the major ones responsible for deaths due to communicable diseases. Now, looking at the danger of spreading of communicable diseases, it is important to manage these diseases in an optimum manner. So, to manage these communicable diseases, we need to do the following. Number one is disease surveillance. Most countries have established disease surveillance systems to track communicable diseases. These systems use various data sources such as reports from the healthcare providers, laboratories and hospitals to monitor the incidence rates and identifying outbreaks. The goal of infectious disease surveillance are threefold. Number one is to describe the current burden and epidemiology of disease. Number two is to monitor the trend, and number three is to identify outbreaks and new pathogens. Second is the vaccination. Now, vaccination is highly effective. This is the most effective approach to prevent the spread of communicable diseases. Vaccination is simple, safe and effective way of protecting you against harmful diseases before you come into contact with them. Now, it uses your body's natural defense to build resistance to specific infectious and make your immune system very stronger. Vaccinations not only prevents occurrence of disease to the one who is vaccinated, rather it also helps others not to get infected. There are small children who cannot be given vaccination, and vaccination also not administered in some cases to the patients who are seriously ill. But in both the cases, the probability to catch the virus is high. So by vaccinating most of the population, it helps to halt the spread of the disease. Number three is contact tracing. Now, contact tracing involves identifying individuals who have come in contact with the infected person and ensuring that they are evaluated, tested and treated accordingly. This approach can be critical in controlling the spread of communicable diseases, especially when it comes to highly infectious diseases such as tuberculosis or STIs. Now, according to WHO, the monitoring process or contact tracing can be broken into three steps. Number one is that we have to identify the contact, then we have to list those contacts which are being infected, and then the follow-ups takes place. Number four in this category is health education campaigns. Now, they are very important. Education campaigns can help inform the public about how to prevent the spread of communicable diseases. These campaigns can cover areas such as how to properly wash hands, prevent mosquito bites and practice safe sex. Australia, for example, has run a highly effective nationwide awareness campaign targeting various communicable diseases such as HIV, AIDS, hepatitis, STIs and other infectious diseases. Next to this is we can also quarantine and isolate. So, quarantine and isolation are measures taken to separate the individuals who may be infected with a communicable disease to prevent the spread of the disease to others. Isolation and quarantine help protect the public by preventing exposure to people who have a contagious disease. Isolation separates sick people with the contagious disease from people who are not sick. So then we can also build up herd immunity. Herd immunity, also known as population immunity, is the indirect protection from an infectious disease that happens when a population is immune either through vaccination or immunity developed through previous infection. WHO supports achieving herd immunity through vaccination, not by allowing a disease to spread through any segment of population, as this would result in unnecessary cases and deaths. The percentage of people who need to be immune in order to achieve herd immunity varies with each disease. Let us now look at the India's immunization program. According to Ministry of Health and Family Welfare, Government of India, India's immunization program was launched in 1985. It is one of the largest health program of its kind in the world, catering to 2.7 crore children annually. The program provides vaccination against 8 life-threatening diseases, that is diphtheria, whooping cough, Haemophilus and influenza type B causing pneumonia and meningitis, tetanus, polio, tuberculosis, measles and hepatitis B in the entire country. And this, in addition, vaccination against Japanese encephalitis is also provided in selected endemic districts of the state of the country where these are prevalent. Recently, rotavirus vaccine has also been introduced in 4 selected states, namely Andhra Pradesh, Haryana, Himachal Pradesh and Odisha. The Indian mission of immunization, that is Mission Indradhanush, which means rainbow, launched in December 2014, is to identify, enlist, mobilize, vaccinate and track to achieve full immunization. Now let us try to figure out main differences between communicable and non-communicable diseases. This will make us understand the next part of the module, which is on epidemiological transition in India. Now looking at the definitions, communicable disease spread from one person to another. It can spread through water and air, etc. Whereas non-communicable diseases are not transmitted from one person to another. If we see the causes, then in communicable diseases, pathogens that are highly infectious and vector transmits these diseases. Whereas in non-communicable, there is no pathogen involved and the cause is allergy, malnutrition, illness due to internal factors, lifestyle changes, environmental abnormalities, etc. What are the agents that cause infection? So there is no agent in non-communicable disease, but in communicable diseases it can be pathogens, virus, bacteria. Inherent factors, definitely in communicable, though there are no inherent factors mainly involved, but in non-communicable, inherent factors play an important role. Examples for communicable are AIDS, tuberculosis, cholera, whereas for non-communicable it can be heart diseases, diabetes, etc. Now these diseases which are communicable, they are also very acute, whereas non-communicable are considered to be chronic and they last over a period of time. Treatment, if we see, then there is a difference in treatment. Also we can take precautions by vaccinating people in communicable diseases, and we can also do some traditional therapies. But in non-communicable diseases, mostly lifestyle changes are important. In some cases surgical or specialized methodologies are also adopted. What is epidemiological transition in India right now? As you have learned in the previous modules, the epidemiological transition theory outlines the changes in the pattern of diseases and health conditions that occur as a population undergoes socio-economic and demographic shift. Abdul R. Omran, the pioneer of epidemiological transition theory, highlights the following propositions of the theory. Number 1, that the theory begins with the major premise that mortality is a fundamental factor in population dynamics. Second is that during the transition, a long-term shift occurs in mortality and disease pattern, whereby the pandemics of infection are gradually displaced by degenerative and man-made diseases as the chief form of morbidity and primary cause of death. Number 3 is during epidemiological transition, profound inequities or differentials in health and disease changes occur according to age, gender, race or ethnic origin, social class and indigenous status. During the transition, systematic variation in the pattern, pace, determinants and consequences of the health, survival and population changes distinguish several models of epidemiologic transition. Omran originally identified 3 stages of epidemiological transition, that is the age of pestilence and famine, age of receding pandemics and the age of degenerative and man-made diseases. Later he added the 4th stage, and that was the age of declining cardiovascular mortality, aging, lifestyle modification and emerging and resurgent of diseases. 5th stage, which was a futuristic stage, was also added, and this stage basically aspired quality of life with paradoxical longevity and persistent inequities. So where does India lie? So India lies primarily in the transitional stage between stage 3 and stage 4 of epidemiological transition. India has experienced a decline in infectious diseases over the years, but they still remain a significant health issue, particularly in rural areas. However, the burden of non-communicable diseases such as cardiovascular diseases, diabetes, chronic respiratory diseases and cancer is rapidly increasing. For example, in India, India has contributed to the largest drop in the cases region-wise for approximately 20 million to 6 million. The percentage drop in malaria cases was 71.8% and deaths were 73.9% between 2000 and 2019. India achieved reduction of 83.34% in malaria morbidity and 92% in malaria mortality between 2000 and 2019. In India, 2016, cardiovascular diseases contributed 28.1% of the total deaths and 14.1% of the total disability adjusted life years, compared with 15.2% and 6.9% respectively in 1990. Within India, the rates of CVD vary markedly, with highest in the states of Kerala, Punjab and Tamil Nadu. Life expectancy in India has been steadily increasing. According to UN World Population Prospects, the life expectancy at the birth in India has risen from 57.66 years in 1990 to 70 years in 2020, indicating improved healthcare and disease management. According to Global Burden of Disease study, the leading cause of death in India are heart diseases, chronic obstructive pulmonary disease (COPD) and diabetes. These diseases are typically associated with stage 3 and stage 4 of epidemiological transition. India is also experiencing a demographic shift with a rapidly growing aging population. The proportion of population aged 60 and above is projected to reach 13% by 2025, which is a special characteristic of countries which are in stage 4. Now, to summarize, India has been impacted by various fatal infectious diseases in the past. The disease like plague, cholera, typhoid and malaria have impacted Indian population to large extent. India has reported over 18 million confirmed cases and more than 2 lakh deaths during COVID-19, though the number of deaths caused by the pandemic remains a topic of debate due to potential underreporting. Vector-borne diseases in India includes malaria, chikungunya, dengue, filaria, etc. Food and waterborne diseases in India includes typhoid, cholera, hepatitis A, jaundice, etc. In 2021, the leading communicable diseases causing deaths in India included pneumonia, acute respiratory infection, acute diarrheal diseases, viral hepatitis and enteric fever. The Indian State Level Disease Burden Initiative highlights that while non-communicable diseases have overtaken infectious diseases in terms of overall disease burden, communicable diseases like diarrheal diseases, lower respiratory infection and TB, that is tuberculosis, still pose major public health challenges, especially in poorer northern states. Thank you so much.